Boa noite a todos. A reunião de hoje, que tem o patrocínio da GE, a gente tem a honra hoje de ter a presença aqui do Dr. Ernest Garcia, né? Dr. Ernest, todo mundo já conhece, mas ele é o diretor do Centro de Pesquisa e Desenvolvimento de Cardiologia Nuclear do Emory University. Então hoje ele vai falar para a gente sobre os avanços em spect cardíaco, né? Instrumentação e quantificação. Por favor, Dr. Ernest.
Thank you. It's a great pleasure to be here. Sorry I don't speak Portuguese. I could do it in Spanish, but maybe next time I'll try some combination of the 3 languages. I truly appreciate the invitation to basically to visit your home, and I even appreciate even more the fact that you showed up for the lecture. You know, after one travels very far, it's sometimes very disappointing to reach a place and not have people listen to the message you want to send. So I have a story of something that happened to me about a month ago, where I had to give this lecture in the mountains of Georgia, and I drove to this university in the mountains in the rain, and when I got there, I walked into an auditorium like this, and or bigger actually, and there was only one person there. And you know, when I got to the parking spots, and it's only one car, I got concerned. I checked everything. It was the right place at the right time, one person. And you know, my instinct was to leave, but it was raining. I was tired, and I felt bad about this poor person who also came to listen to me. So I decided to give the lecture, and I turned on my computer, hooked it up to the monitor, and gave my 1-hour lecture. When I finished, I asked him if he had any questions. He said no. Then, as I was packing and getting ready to leave, he said, excuse me, it wouldn't be appropriate for you to leave now. And I said, why? He says, I'm giving the second lecture. So you can see how encouraged I am to have you here in the audience. All right, so today we're going to talk about a lot of things. And you know, we're getting into this part of technology that some of it sounds a little bit like magic. So I will be around after, and I mean, you're welcome to ask questions. And I always like to try to answer the questions that you have, but I anticipate some of those, and some things that I think you should understand about the new technology, both from the hardware, software point of view. And so let's just get into it. I was honored in Denver last week to give the Mario Verani lecture. And I'm sure all of you known of him or knew him, and great physician from Brazil. The title of the lecture is Nuclear Cardiology, We're Almost There. And I went through many of the strengths of nuclear cardiology, why we are where we are, and why we'll continue to be around for a long time. So I'm not going to give you that lecture, but I do want to show you one slide from that lecture. And we need to understand, when we compete with other modalities, what is our strength? And we have many of them. I'm just going to point out that whether we compare nuclear cardiology to CT, we compare it to MRI, we compare it to echo, we have superior contrast resolution than any of those. So let me show you an example here from this paper in the European Radiology Journal in 2008, where they're developing techniques, as you know, for measuring perfusion with ion contrast agent and multiple detector CT. And you can see the image here where there's a region in the wall that is reduced in the uptake of the contrast agent, and this indicates that it's hypoperfused. In fact, it happens to be infarcted, but they compared to this very poor nuclear medicine, nuclear cardiology perfusion image. And you can see very poor spatial resolution here compared to this nice spatial resolution, but yet the hypoperfused area, the infarct, is much easier to see even with this old technology in this old machine compared to the new technology. So what's amazing now, and I'll talk about some of these things, is that now we move to new technology. We go several generations, both in terms of agents, perfusion agents, and imaging agents. So this is a CCT machine, and now we're acquiring in 2 minutes for stress and 4 minutes for rest. And you can see, comparing the quality of these two images, how much higher contrast resolution this has, both in delineating the cavity and the stress-induced perfusion defect and the reversibility of the defect. And here, comparing with looking at a fluorinated PET perfusion agent, you can see how well delineated this defect is at stress and how well it normalizes at rest. And in fact, the quality is so good that we begin to see the left atrium and we can see the right ventricle and so on. So our improvements industry continues to invest in our field. So briefly, this is a very brief outline we want to talk about, but we want to talk about hardware, detector design, and software signal processing, reconstruction. There's been tremendous improvement in reconstruction techniques, and I want you to understand them, because again, it looks a little like magic. And then we'll talk more about image analysis. So just like me, you know and love the dual detector conventional spec camera. And it's been a great machine, and we used it for many, many years. But the limitation of the machine is that in general, it was designed for nuclear medicine procedures beyond cardiac. It's for those places that were doing not only heart, but other things. And you can see that what happens is the heart occupies just a small region of the crystal, and you're paying for all this detector, and you're hardly using it. So the idea is, how can we move forward and be a little bit smarter as to how we design this detector? So now there's a number of companies that have designed a new generation of dedicated cardiac ultra-fast acquisition scanners, where instead of having 2 detectors, you have multiple detectors. So we'll briefly talk about a 3-detector system, a 9-detector system, and a 19-detector system. And the beauty is that they do look at the field of view where their heart is, and of course it increases the count sensitivity tremendously. And again, the unexpected surprise is that it also increases energy resolution, spatial resolution, contrast resolution, temporal resolution. It's like, you know, when not only when I went to school, but when I gave lectures, I kept saying, that's impossible, you can't do all that. You got to give something up. So this is, these are 3 different designs, and there are 3 that are commercially available. They're clinically validated. They all had undergone multi-center trials. They're multiple, meaning there's more than 2 detectors, and they're solid-state detectors. And they're cardiac-centric. We're not even sure spect is the right word, but let's call them spec systems. And this is the D-spect approach from Spectrum Dynamics, and you see a rectangular detector. And there's 9 of them that fan. They're actually moving, fanning over the field of view of the patient. This is the Cardias 3 from DigiRad, and you can see there's 3 detectors. This is more like conventional Anger cameras, but in fact they use the solid state technology to some degree. And then there's a system that I've had the most experience with, even though we've had many of these, all 3 of these are at Emory at some time, and we even have other of these at Emory that we are evaluating. But the one we use every day clinically is the Discovery Nuclear Medicine 530C detector from General Electric, and this has 19 ZCT detectors. Now it's important to compare apples to apples. So you probably have heard that GE bought the company that makes these solid-state detectors, which Spectrum Dynamics used to use, and they have looked and I think found another manufacturer. But before that, they were both using exactly the same detectors from the same company, except that detector by detector, the GE used 19 versus 9, and the cost of the system is in these detectors. Now these detectors are pixelated, meaning that the size of a pixel is roughly 2.5 millimeters, and the spatial resolution you're going to get is roughly between 3 millimeters to 5 millimeters, where I wonder if you know the resolution you have in your system now. Conventional state-of-the-art spect systems in the heart is roughly 10 millimeters resolution. So that in itself is quite an improvement. But the other interesting thing with this system is that it's easier to think about it as a PET scanner than it is as a SPECT scanner for several reasons. One of them is that once you start acquiring, nothing moves. So as opposed to conventional SPECT that rotates around the patient, or the D-SPECT that moves around, or the DigiRad that also rotates around the patient, you're simultaneously looking at 19 pinhole projections from different projections. But the interesting thing is also, it's not only PET, it's 3D PET. What do we mean by that? Means that not only do we look at angular sampling in this dimension, from here to here, but we're also looking at angular sampling in the other dimension. So if I count, there's 9 here, times 3, you can see there's actually room for 27, but to make it affordable at this point, it's being released with 19 detectors. So the ability of having this 3D imaging, you will see an example I show you. For example, in ladies, when we're imaging breasts, we can see, like in planar imaging, above and below the breast, and there's a lot less breast attenuation with this machine than there is with conventional SPECT. Before I forget, the other benefit of all three of these machines is that they acquire in list mode. So thinking again like PET for this particular machine, if we want to start thinking about measuring flow, and what's limiting us now is not the detectors or the camera, because this camera can do it, it's more the tracer. We need a tracer with a high extraction fraction, and we have actually two. One tebaroxine that went out of, is not being commercialized at this point, and the other one is called I-123 rotenone, which is actually an analog of the fluorinated flurpiridaz, and has extremely high extraction fraction. So very soon, not only in PET, that's already happening, but also in SPECT, you'll be able to measure flow. The other thing I want to make sure I don't forget to tell you is that these pinholes are made out of tungsten. So the system is really, and by the way, the same thing with the collimator for D-SPECT. The tungsten gives you a much better range for imaging thallium to I-123. So you know, with thallium, the problem is the lead X-ray picked up by the thallium. So it's the lead from the collimator that's creating a peak that reduces the contrast of the images. And in I-123, you know, there's very high energy photons at a low abundance, but it can hurt you when you start collimating the lower photons where the high go through. So I know I'm throwing a lot of things to you. I just want to absorb some of it, and then we can talk some more about it. So this is again the Anger camera, less Anger that gave us this device 50 years ago, and we all used it for many, many years. And you know how this works. The scintillator absorbs the gamma ray, converts it to light, it goes to the light path, and is seen by all the photomultipliers. And you can see this is what one photomultiplier looks like. In CCT, what happens is the gamma ray comes in, goes into the solid state detector, and it gets converted into an electrical pulse right within the pixel. So there's truly no scintillation. Now I realize in Brazil you call nuclear imaging scintillography, so that's a problem for you because it's no longer scintillography. But compare the size, one photomultiplier to one of these detectors. But also look at the energy resolution. So here is imaging simultaneously I-123 and technetium 140 keV. And the purple is the anger camera from a state-of-the-art spect system. Happens to be the Ventry system, and you can see that this is the region between the two peaks, where with the Alcyon technology, which is what GE calls this technology for solid state, you can see much better delineation of the two photo peaks, even though they're imaged simultaneously. So we're comparing 10% energy resolution to a 6% energy resolution. Now, this is going to help us in a lot of things, but remember, when we're counting with spect, one of the things we want to do is correct for scatter. When you start out with a 6% energy resolution, a lot of the scatter is already being rejected without you having to do scatter correction. So you need to start thinking a little differently, and what you're going to see is that everything works synergistically to make the images not only look better, but be more accurate from the concentration point of view. Because one of the strengths of nuclear cardiology is that our pixel value are linearly proportional to the radionuclide concentration, which in perfusion is also proportional to blood flow. Now, so what are you giving up? Well, one of the things you give up is the field of view. As you see, everything is focused on the heart. All the detectors are looking at the heart. So you can see that the field of view in the three different directions is 22 by 25 centimeters, 20 centimeters this way, and 19 centimeters that way. So it's really very similar to a PET scanner. So another reason, when you pay a lot for detectors, the field of view tends to be smaller. But this is pretty, it's quite large. It's difficult, and if I go back to the planar projections here, the detector will actually position the heart for you. So only in very unusual situations with someone who's learning will you get truncation putting the heart out of the field of view. Okay, let's look at some images. So here is a normal patient. Here, using the CardioMD system that we had at Emory from Philips, with a 12-minute stress image and a 14-minute, this is a typo, rest image. And you can see this is quite a nice looking images. There's nothing wrong with these images. But in the same patient with the same dose, which has 30 millicuries for stress, 10 for rest, you can see imaging at 2 minutes of stress, 4 minutes for rest. These are better looking images. So it's 1/5, 1/6 of the time, higher contrast resolution of the chamber, higher contrast and spatial resolution of the myocardium, better uniformity, better separation of the gut activity from the heart because of the higher energy resolution. Now, this is just to show you the normal database that we're using. This is for conventional spect cameras, female and male with sestamibi. This is with attenuation corrected, and this is with the Alcyon technology, gender combined without attenuation correction. So in fact, you can see much more homogeneous uptake, again, making it easier to make the interpretation. Here's another patient. This is an abnormal patient with left circumflex disease, and again, the conventional spect, I think we would all agree, beautiful images, right? There's nothing wrong with these images, whether you look at the planars, the tomographic stress versus rest, and you see that there's a defect here in the lateral wall that somewhat improves, again, with the 12-minute stress, 14-minute rest. Look at the discovery system, 2 minutes and 4 minutes. You can see not only the increased contrast resolution, but look at the lesion, and look how well it normalizes. So the ischemia is also easier to detect. So all these things are working in your favor. Now, this is a recent paper. In fact, in Denver, it just won the award for the best paper in Journal of Nuclear Cardiology for this year. And this is from the Mount Sinai people. And here what they're showing is, okay, let's start cutting the exposure to the patient by cutting the activity in half, 15 for stress, and 5 for rest. What happens if we also cut acquisition time? So this is 3 minutes for stress compared to a 5 minute for stress, compared to conventional spec, 15 minutes. And again, you can see very little difference between 3 minutes and 5 minutes, and significantly superior to conventional spect because of the fact that now you're using lower exposure to the patient, lower activity injected in the patient. So you can get both higher throughput and lower dose if you choose to do so. So this is now from the paper that Fabio Esteves published in the Journal of Nuclear Cardiology in 2010, actually. So, and in our validation for 3 centers, this center in Israel, Rambam, Mayo Clinic, and Emory, you see that reading the conventional spect twice, we looked at the reproducibility of the read versus comparing the discovery system versus conventional spect. Very similar results, whether there was a defect in the wall or there was the defect was absent or present. And similarly, again, if you go to this, somehow I don't have the slide with the actual publication, but you would see, you can find it and see that also the volumes and the ejection fraction agreed quite well, comparing the 2 different systems in these multi-center trials from the 3 different institutions. Here's an example of what I was talking to you about. Here's, this is a lady, 5'3", 206 pounds. I realize these are not the units you use, but this is a short, chubby lady, which I know you, well, I think in the United States we have a lot more of those than you have here, but you can see the breast shadow over here, and you can see that breast shadow being realized over here. And true, again, this is conventional doses, conventional acquisition times, conventional spec. Now, look what happens when we go to the discovery system. Again, the same setting, it's not that we re-inject or anything like that, same dose, and the 2-minute, 4-minute acquisition time, you see that this reduction of counts in the anterior wall has gone away. Now, I still believe in attenuation correction for a lot of reasons. This machine, by the way, is also quite easy to do prone imaging. And some of you like prone imaging, and if you don't do attenuation correction, I would, because it's so fast, if there's any question for inferior wall problems, you should definitely do prone imaging in those people. But here's a slide from the work of Da Silva back in 2001 in an animal experiment of the in vivo uptake versus the ex vivo after the heart was taken out of the animal and measured on a well counter. And you can see with no correction versus attenuation correction versus attenuation correction with correction for partial volume effect, which has to do with the resolution of the system, you're getting much truer concentration out of the pixels, but also higher contrast between hypoperfused tissue and normal tissue. And this is from a meta-analysis that I did in 2007, looking at studies from over 1,000 patients, showing the increased gain in specificity and particularly normalcy rate and no loss in sensitivity. So how can you do attenuation correction in these devices? Well, the DigiRite system actually has an X-ray mounted where you can do attenuation correction at that particular time. The Discover system also has a flavor of it, I believe it's called the 570, that has combined solid state and volumetric CT attached to it. What we do at Emory on every patient right now is we actually we want to get calcium scores on every patient, and we also do an attenuation CT, a transmission CT on every patient. I think eventually we'll be able to use one or the other, we'll have to do both. And then we bring that CT study into the 530C system, and using their software, we align them, and on every patient, we're doing attenuation correction. So you see in this patient, before attenuation correction, there was this region in the base of the inferior wall that could cause some concern. It looks subtle, but why worry about it when you can correct and it goes totally away with the attenuation correction. All right, so that's enough about hardware. And again, if you want to ask me questions, either right after I finish or while we socialize, we can talk about it. But let's talk about reconstruction, because these machines, all these new machines, have new reconstruction techniques, and well, let me not jump the. Let's talk about two concepts, okay? Resolution recovery and noise regularization. And you might think of noise regularization as filtering. You might think as resolution recovery as depth-dependent resolution correction. And it's true, that's what they help with that. But this is truer, a lot truer reconstruction, where it's modeling the physics of the system. And so in filtered back projection, for example, if you're looking at counts in voxels, and you get so many counts in this voxel, what the software does, the reconstruction algorithm back projects through three-dimensional space those counts, and with the assumption that they came from a radioactive point source over here. But we know if you look at a conventional device, a conventional parallel Hall system, a Hall does not see just this ray, a Hall sees a whole cone of activity. So the reconstruction now, an easy explanation is instead of back projecting a ray, is back projecting a cone. So this is an assumption, this is reality. And again, everything that's happening now, we're getting closer to the truth in the reconstruction process. Now, we put this together with noise regularization. Let me take you through this example. So here is a vertical long axis image, which actually was filtered, but assume that it wasn't filtered, and I take a count profile across it, and I get this count profile, meaning that this is the region of the normal wall, another normal wall, and there's the perfusion defect. Oops, a little sensitive. And here's where the defect is at. So the conventional approach we've been using for many, many, many years is to apply a filter to these images, the projections, while we're back projecting them, to get rid of the high frequency noise in favor of low frequencies. And this is exactly what the vertical long axis would look like in this particular patient. But look what happens now. Because I'm getting rid of the high frequencies, I also lose the definition of the defect and the contrast of the defect. So I get a very smooth image with low frequencies, but I've lost definition. Now, with noise regularization, it is not filtering. What it is modeling the response of the system, which is specific to the activity and the number of counts that you're getting. And look what happens now. We are replacing the noisy count profile with a smooth count profile, but going through the middle of the count profile. So guess what? We get the smooth response, but we keep the contrast. And you see the contrast here compared to this. This is the same patient, and the contrast here in the chamber compared to that. Oh, and yes, by the way, this was 12 minutes, this was 2 minutes. Okay? So, even if you can't afford the newer fancy detectors, you can afford this reconstruction, this new reconstruction algorithms. And now, all the major companies, Philips, Siemens, General Electric, and Digirad, have different flavors of this type of reconstruction algorithms. And even a company which is a smaller company, Ultra Spect, actually started promoting this kind of reconstruction algorithms. So a lot of people have implemented this with conventional cameras, and here from the work of Gordon Dupuy, published in 2008, which I then summarized in a review paper in 2011. And here you see an algorithm, this particular, it happens to be wide beam reconstruction from Ultra Spect, but you can see full time, that is the 12 and 14 minutes filtered back projection, with the 30 and 10 millicurie, and you can, again, very nice looking images. But now you can cut the time in half, acquire in half the time with this new reconstruction, same old detectors, and you in fact get higher contrast, better looking static images, better looking gated images. So now we have both software and hardware that we can use to either reduce dose, increase efficiency, or do a compromise somewhere between the two. So here's the conventional protocol I showed you: 4 minutes for rest, 10 millicuries, 2 minutes for stress, 30 millicuries. That's a total of 12 millisieverts with a total acquisition time of 6 minutes. I show you images where it was cut in half. So this is 5 millicuries at rest, acquiring for 8 minutes, 15 millicuries at stress for 4 minutes. I cut the radiation in half, double the time, but guess what? This is still much less than the time you're using these days. So 6 millisieverts in 12 minutes. And by the way, the American Center of Nuclear Cardiology's goal is to reduce radiation exposure to less than 9 millisieverts in at least 50% of all patients by 2014. And you can see we can do that easily now with the technology that we have at hand. And we can even cut it one more time to acquire for 24 minutes for 3 millisieverts. There is no reason why we can't cut radiation. I believe I'll be showing you some slides on image fusion, where we fuse CT angiography with perfusion. And again, now we're adding more radiation, and people say, are you concerned about the cumulative radiation of the two studies? Well, you can do prospective CTA with 1 millisievert. You can do now nuclear studies with 3 millisieverts. That's 4 millisieverts, a lot less than what we're doing today in your labs and many of ours. But part of the message here is we have a saying not to throw the baby away with the bathwater. I want to make sure that all this gain is not just translated to reducing radiation. And we could talk, if you like to, about concerns about radiation exposure, low level of radiation exposure. But I think the value of the test is outcomes divided by cost. We can reduce the cost by doing the study faster and injecting less. We can increase the outcome by making the images more accurate. And for example, one way we could use the counts, which we haven't done routinely, is respiratory gating. Respiratory gating causes us multiple problems. Here you see in this paper by Kowalski that, so one thing is for the heart to beat, the other one is to breathe, where the heart moves up and down. And what happens in the study, which is actually not too bad, but it's definitely measurable, the inferior wall is reducing counts because of the breathing, where when you do the respiratory gating, it goes away. But even worse than that, you can see in this NCAT digital phantom that the liver moves in and out of the field of view of the inferior wall of the heart. These are those hearts that appear that the liver somehow has penetrated the heart. Of course, that's not what is happening. It's just that it's smearing in and out with respiratory gain that goes away, and is the one way that we can make images much nicer. Okay, so I finished with the software part related to reconstruction. Now I want to talk about my baby, which is quantification. And just want to leave you with a message of how to use quantification to improve image interpretation, reproducibility, and accuracy. So why should we quantify? Well, for a lot of reasons. To optimize image display of tomograms for visual interpretation. I want to make sure you understand that even when you look at the slices, if you use any of our programs, the Emory program, the Cedars program, the Michigan program, all those images have been quantified to optimally display them. If you're older like me, and you tried the old days of bringing an image up at a time, first of all, it took an incredible amount of time. Second, they were not optimally displayed, and all kinds of problems would come up. And I'll show you some of those problems. So we quantified to provide a pattern of tracer distribution in normally perfused myocardium, to flag potential abnormalities for diagnostician, to confirm or disconfirm, to provide a second objective interpretation, to apply quantitative objective criteria in parameters difficult to assess visually, such as percent of myocardium hypoperfused, grams of infarcted tissue, viability criteria, ejection fraction, LV desynchrony, and to offer quality control parameters for the study. In the United States, more and more, the referring physician and the insurance companies are requiring quantitative numbers before the patient undergoes treatment. So at Emory, for example, we require 10% ischemia, 10% of the LV before you send the patient to the cath lab. The CMS, the insurance company, requires an ejection fraction 35% or below before the patient can go to resynchronization therapy with a QRS of greater than 120. So more and more, we're being driven that way. So again, just to remind you, and I know that all of you use some sort of flavor of this types of quantification. The advantage of quantification is also integrating all the information. So here we see from the program we developed, again, we're looking at the images, but these images have already been optimized for display. We'll see a rotating picture of the stress and rest for quality control. We see in this patient a defect in the anterior wall that reverses. Stress, rest, short axis, vertical long axis, horizontal long axis. We compare versus the normal databases. We have 19 different protocols in the Emory Cardiac Toolbox. We see the definition of the defect, that stress. You can see visually that improves, so we can quantify what percent has improved. We see the volume time curve. We see the thickening polar map. We give you three-dimensional displays against a ruler, meaning that the polar maps never change in dimension, but these guys, this is the LV gets bigger and bigger as the heart gets bigger and bigger. So we do have the volumes here, but you can look at this visually and assess it. And then you can also, we estimate the score for each of the 17 segments of stress and rest, which is being used for the SUM scores in many of the reporting systems. So again, we quantify, so not only visually, but quantitatively, the external location of the perfusion defect and reversibility. So in the same patient, you see this defect occupies 29% of the myocardium, 51% of that is in the LAD territory, and 56% of that 29% reverses and is whited out in terms of the region that is definitely ischemic. And then the question is, for example, question everybody asks me, is the rest infarcted? And so there are tools for infarction. Using this tool, developed the Mayo Clinic as percent of maximum, anything below 50%, and you can see that only a small region is below 50%. This patient happened to have a subendocardial MI. So the next question, is that indicative of a true MI, or could it have been some sort of artifact? If we had done attenuation correction in this patient, would have gotten, and if it was attenuation artifact, would have gotten rid of that. And of course, we can visually see the ejection, the wall motion. We can look the thickening in terms of the color change. We see these thickening maps in terms of it's color coded, and we get the numbers and the volume curve in this patient at 61% ejection fraction. And then the other thing that we're quantifying this day is the amount of left ventricular desynchrony. And I'll show you a few more examples of that, but I want to keep showing you the same patient. And you can see the same stress perfusion distribution in this polar map. This is a polar map of the onset of mechanical contraction, where the lower colors is early, the brighter colors is late. So you can see that it starts over here and it ends over here. And as it comes across this histogram and it hits, you can see the wave of contraction, where wait till it comes back again, and when it hits, and then it's going to end. Guess what? It's ending in the region that where the subendocardial MI is at. So what the histogram is giving you is the number of segments, you can call it pixels or voxel, in the left ventricle versus time of onset of contraction in terms of 360 degrees for a heartbeat. And so this is earlier. The wider this is, the more desynchronous the heart is. Okay, so let's play a game here of trying to interpret the study, or I can go faster and do it myself. But so the first question is this patient normal or does he have multiple vessel disease? How many of you say this patient is normal? How many of you say this patient has triple vessel disease? How many of you don't care? All right, so this is a trick. And so many people would think that, and I'm tricking you because you don't realize that these programs can go wrong, or I can trick you to make it go wrong. So you look at the stress distribution, looks at the entire LVs down, and you look at the rest distribution, it comes back up. You say, this must be a lot of disease that improves. But what is happening here is that I neglected to apply the quantification to normalize it, and it's being normalized to the gut activity. So you see this is bright, and that is being compared to this, and that's the problem we used to have 20 years ago. Aren't you happy I came along? Now when it's quantified correctly, you can see again that it becomes normal, and practically all of you will say it's either normal or near normal distribution. So again, the quantification automatically finds the center of the left ventricle, the radius of the left ventricle, the endocardial, the epicardial side, and it would only look at the counts inside of this. So these are the counts that are going to be used for the polar maps, not any activity outside. And then it finds the apex and the base, so it's also going to align it for you automatically, apex to apex, base to base. All of this happens in a couple of seconds at the most. And as I said, the other thing that it does is compare to normal databases, but appreciate that normal databases for different protocols look different. Look at this female distribution with sestamibi versus the male. In the male you see more inferior attenuation. With attenuation correction it looks different. This is sestamibi distribution corrected for attenuation. But look at PET and ammonia. Ammonia, the lateral wall looks down compared to sestamibi, and it also looks down compared to rubidium. So the beauty of this normal database quantification is that all of these normal patterns of distribution are for you to use and to compare against. And that we use objective criteria. Again, I won't take a lot of the time, but just to tell you that our true criteria so far has been not to use the sum stress score, but to actually use the extent of the abnormality. Greater than 10%, greater than 3% of left ventricle, we call the patient abnormal, to localize it to a territory, 10% LAD, LCX, and 12 RCA. For reversibility, if we see 5% or more, we call it partial redistribution. If we see 15% or more, we call it significant reversibility consistent with ischemia, predicting that the patient will improve function post-revascularization. Okay, another test question. So I told you at Emory we say that 10% or more of the myocardium ischemic, we send them to cath. So as you know, if you've never seen them, you never have them, you should download them. They're free at the American Society of Nuclear Cardiology web pages. There must be hundreds of pages of guidelines. But I'm asking you in this patient, first I'll give you this patient is abnormal, and we'll even talk about it. You can see the defect here in the anterior wall, which improves between stress and rest, and you can see it here. But now the question is, according to guidelines, is it small, medium, or large? So imagine, as many of you do, you work with 3 different physicians, and one day one reads it small, the other one reads it medium, and the third one reads it large. So that's a problem, right? Ideally, you would like all 3 of you to read it the same way. Okay, how many of you think it's a small defect? Don't be shy. Okay, how many of you think it's a medium defect? How many of you think it's a large defect? Rafael has seen the lecture before. All right, so look what happens. Look at the polar map. First of all, just looking at the polar map, you see the defect is a lot more extensive than probably you integrated in your mind. So polar maps help you quite a bit there. Second, look at the number. It's 25% of the left ventricle. And if you look at guidelines, anything greater than 20% is large. So now, if everyone used this program, or a program similar to it, you would say, all of you would read it the same way. Large defect. How much ischemia? 64% of the 25%, so there's quite a bit of ischemia that you and the patient should be concerned about. This patient should probably be revascularized. Sounds like a riot is forming. Okay, all right, another, so this is a female lady, a lady. So how many of you, this patient is abnormal? How many of you think this study is abnormal? How many of you think it's normal? So I'm making you a little paranoid, ain't I? Okay, so you see that at first glance, everything looks normal. I mean, this looks beautiful, uptake, everything is yellow or white type of thing, and maybe you're used to reading in black and white. I feel sorry for you, but but the problem here is in this distribution, which happens to be sestamibi, you expect the lateral wall to be harder than the septum, but guess what? It's not. So when you compare it to a normal database, you're going to pick up on that. So even though it was difficult visually to see it, you can see either in the polar map or in the images if you are careful to look at it, and it will detect additional normality. So in fact, when we published this, not with sestamibi, but with thallium in circulation back in 1988, you can see that quantification of that lateral wall was a lot more sensitive for the quantitative approach versus visual, and no loss of specificity, at least no significant loss of specificity. Okay, other advances, image fusion. So now the idea is what happens when you combine the physiological functional information of nuclear studies with the anatomical information from CTA. And just to try to go a little fast, this study was read as equivocal, either normal or equivocal. The CTA was read as equivocal also, too much classification here, difficult to tell over here, but when we quantified it and we aligned it, we see that the region of hyperperfusion in black aligns perfectly with the region of the anatomic lesions, and we are a lot more certain in saying this patient does have disease. And in fact, when we look at the multicenter trial from Cesar Santana from our group back in 2009, we get significantly better results, not only to looking at just perfusion, but even better than looking at side-by-side perfusion and CTA. This is an example from Gamperli, and this is in a patient with myocardial bridging. And then the problem here is it the diagonal or is it the myocardial bridging? Looking at over here, you say it's tough to think that this could be a diagonal all the way here in the anteroseptal wall. But in fact, when you fuse it, you can see that the bridging is not perfusing the region of hypoperfusion, but the diagonal is. And again, similar to what we showed, they also show that increases the certainty of reading the study. I want to finish with an exciting new technology. New means 6 years. We've been working on this for 6 years, but it's finally getting popular. And this is how in the United States, and I think in Brazil too, we're seeing a lot more patients with heart failure. A lot of the patients that the treatments were good and now they live longer with coronary artery disease are getting into heart failure, and now they're expensive treatments for them, as you know, resynchronization therapy, ICDs, defibrillators, and all kinds of other things. So you know that biventricular pacing is what is called cardiac synchronization therapy, where there are multiple leads that are being placed in the heart, and one of them is being placed in the lateral wall, one in the right side and one in the septum. The question is, so in the United States it costs about $60,000 to do this procedure. A lot of people are getting it. and 30% don't respond to it, don't improve, and in fact, significant number are getting worse. So similar to the issue of improved resolution and improved sensitivity, all this magic technology that we have, we also have the magic technology of improving temporal resolution. And that is, we always acquire 8 frames per cardiac cycle, it's hard to understand, but I'll tell you, and if you ask me later, the temporal resolution is not given by the number of frames per cardiac cycle, it's given by the number of counts per frame. How you like that one? So what happens here is that we replace the discrete points, and these points are, we're sampling a segment, 8 frames per cardiac cycle, which is the thickening curve for that particular segment. We replace, using Fourier transforms, the discrete points with a continuous curve. So now we've gone from 8 frames to how many? Well, we've already published and validated 64 frames per cardiac cycle. And in fact, if I had an infinite amount of counts, we could go to an infinite amount of frames per cardiac cycle. And we could talk about that someday if you're interested. But we're using here the partial volume effect, the fact that when something is thicker, we get higher counts in the center of the profile. When it's thinner, we get fewer counts, and we do that in a linear fashion. So now we can convert these 8 frames, and you will see into 75 frames that we're using for this onset, and you saw one example before. So this is from a paper in 2005 from my colleague Ji Shen, who has pioneered this technique, showing that it works and that generating normal limits. And here is in a normal patient. And you can see, first of all, the normal perfusion distribution. This is a normal phase distribution. Again, you see early onset of mechanical contraction, late onset, this is textbook normal. And again, as you can see how narrow this histogram is. Almost all the segments start to contract at the same time. So this is, again, perfectly normal. Here's in a patient with left bundle branch plot. You can see early, you can see late, and you can see that the distribution had spread quite a bit more compared to that normal patient that I showed you before. And you can see how there is less synchrony in this particular patient. But now the question is, so here's in a patient in heart failure. This is, I believe, class 3 heart failure. Here, you can see how much more desynchronous this patient is. More desynchronous, of course, than the normal, more desynchronous the left bundle branch plot, more desynchronous than the patient with the subendocardial MI. And guess what? After this resynchronization, patients significantly improve in synchronization, both visually and quantitatively and clinically. This patient improved to class 1 heart failure after this successful application. But now look at here, there's 2 different patients. One on the left, class 3 heart failure, ejection fraction of 32% from echo. The other one, class 3 heart failure, ejection fraction of 27% by echo. And now I'm asking you, would you do resynchronization on both, and would you expect both to improve? So let's see what happens here. Well, guess what? The one with the 32% ejection fraction was already synchronized. So we learned early on, if the patient is already synchronized, even though they're in heart failure, every time they try to resynchronize them, guess what? They make every single one of them worse. But if they're desynchronized, like this guy, and you can see this is quite a lot, this patient improved from the 27% ejection fraction to 33, but went from class 3 to class 1. So already showing this is one group of patients that should not be resynchronized with this technique. But beyond that, we've done a lot of work with Bax's group in the Netherlands, and actually we published a paper with Dr. Meneghetti, who's in the room, looking at various applications to this. And we've learned 2 other things. One, you can't place the left ventricular lead into a wall that's infarcted because it's not viable. The electricity doesn't propagate very well. Guess what? Perfusion imaging, that tells you there's an infarction there. So now you see the dysynchrony, the amount of dysynchrony, and you see where the lateral wall is infarcted. And if you're going to put in the lateral wall. The other one is we've also learned, and that was just published in 2011, just recently, probably less than a month ago, again, Bax's group with our group, that it also matters the latest site of mechanical activation with the LD lead position. So now, if this is the latest site of contraction, and this is the lead position in the same wall, we say that they are concordant. If this is the latest site of activation, and this is where the lead is placed, we say it is discordant. And guess what happens? When it's concordant, the patient gets better. When it's discordant, the patient doesn't get better. And by getting better, I've been surprised that not only does the ejection fraction improve, like in this patient from 32 to 44, but look at the volumes, was significantly reduced. So the heart reverse remodel to back to normal situation, where the discordant, the ejection fraction significantly reduced, the volume increase. Very powerful technique where nuclear is helping in heart failure, and where we're helping now the electrophysiologists direct the treatment. This is true image-guided treatment. So hopefully I've excited you. Hopefully I didn't worry you. But you can see we have a lot of tools available for us. So we have a very bright, not only future or present, and it's for you to take advantage of. Thank you for your attention and for showing up from my lecture.